Hi, I'm Dr. Neil Kamal Swaras. I'm a board-certified developmental behavioral pediatrician at Kentucky Children's Hospital and assistant professor of pediatrics and family and community medicine at the University of Kentucky. I have been fellowship trained at the University of Maryland, Baltimore in developmental behavioral pediatrics, which is a subspecialty of pediatrics, dealing specifically with children with developmental behavioral problems. I see the whole spectrum of conditions, including developmental delays, prematurity, all the way through more significant disabilities, autism and cerebral palsy, as well as learning issues, academic concerns. My particular area of interest and expertise is in the autism spectrum disorders. I also participate in education at the University of Kentucky with the graduate certificate that Human Development Institute has, but also in the education of medical students at UK's College of Medicine and with trainees in the departments of pediatrics and family and community medicine.
Hello, this is Dr. Neil Kamal Swaras. I'm a developmental behavioral pediatrician at Kentucky Children's Hospital, and I am going to be speaking about factors influencing child development. This is 10 lectures all in one because the factors that influence child development are vast and numerous, and I'm only trying to encapsulate a few today to give you a general gist of the vastness and the interplay between the factors. One of the more important publications out there in 2000 was From Neurons to Neighborhoods by the National Academy of Sciences, and I believe this would be a very good reference point for you. There are a lot of information from that publication that I have taken into this presentation, and it is available online as a PDF file that you could read if you were so inclined. One of the big issues has always been related to development and human beings in general is the influence of either what's called nature versus nurture. And this is a centuries-old debate going back to the 4th century BC when Plato believed that human beings are born with innate knowledge and that the environment really merely reminded them of the information they already knew. But as typically happens, the student disagrees with the teacher, and Aristotle said that no, humans were born with no knowledge, but they acquired it through experience. This ongoing debate continued through the centuries, and the more famous interpretation was the tabula rasa, or the blank slate, that John Locke and Francis Bacon propounded, and they were called empiricists. And their idea was that human beings are a blank slate, and basically they acquire knowledge by interaction with the environment. And the disagreement came from Leibniz and his teams, which talked about the internal aspects, that all information was already internalized, and it merely expressed itself with interaction with the environment. In this century, we have done more and more studies, and in twin studies in the 50s and 60s, they demonstrated that this polarization was really artificial, that there was both aspects, the intrinsic as well as the extrinsic, were important. And with great advances more recently in neurobiology and genetics, this has confirmed that the polarization is indeed artificial. And the shift from nature versus nurture has become more of nature via nurture, and this is the interactionist theory, which means that both points of view are equally important and there's an interaction between the two. There's been much debate yet about which component is more important, but the better idea is to show that the two concepts are inseparable and complementary to each other, but not distinct, and they act through each other in varying ways. And I'll give you a good example. Let's take a child who's been adopted by a family. You've got the intrinsic, which is the heredity of different psychiatric and genetic conditions that the biological parents of the child push towards the child and helps develop the child's antisocial behaviors. Now, you've got the adoptive family with their intrinsic warmth and their nurturing abilities, and that reflects in their positive disciplinary practices. But now you see there's a bidirectional interaction between the child's behaviors influencing the parents' disciplinary practices and the disciplinary practices influencing the child's behaviors. And so, the outcome of this can be one of many depending on which predominates, and so you can see that biology and environment play an important role in shaping both ways. Now, when we talk about development in children, we're always talking about the streams of development or the different themes of development. We've got the motor, which are the gross and fine motor domains. We've got language and adaptive or self-care. And we've got the cognitive and socio-emotional. Now, it's good to conceptualize development as a stream because, it's always flowing in one direction, which means children's development always progresses. If there is ever a regression or going back, that is a very bad sign needing to be explored further. So you've got these streams, but as you know, a stream does not flow at a set rate. You've got faster patterns, slower patterns, and this is what happens with development. You've got, sometimes you move through your milestones quicker, sometimes you take a longer time, and it's very variable. There is no real pathology that is so distinct from normal. There's always gray zones of borderline. The factors that influence development, just for the sake of convenience, we can categorize them, and one is called the innate or the intrinsic, and this is the genetics, the prenatal environment, so how the child is exposed to different environments in the womb, and the temperament or the innate temperamental characteristics that the child comes out with. And you've got the environment, nutrition, housing, medical care, safety, education, and family support. And we'll go through all these step by step. So let's first talk about the innate. Genetics has been very predominant now in how we conceptualize anything because previously developmental psychologists used to have theoretical constructs with very little ability to actually test these, but now they could be validated because we're understanding better and better about the human genomic map. And since 1999, since we've been able to decode the human genome, we're actually able to map certain behaviors and developmental traits to certain genes. And so we can use neurobiology and genetics to help explain behavior and development, because all development behavior originates in the brain, and therefore neurobiology is the most important. A good source to get information about genetics in psychology is the American Psychological Association. They have a web page in their science section which talks about links, resources, research opportunities. And just as an example of how genetics plays into behavior and development, we have managed to detect certain genes which are found to be linked with ADHD and substance abuse, certain genes with certain behavioral characteristics and personalities like neuroticism and harm avoidance, that's the serotonin gene. So as you can see, little by little, we're able to detect, for example, Down syndrome. I mean, in the past, people did not know Down syndrome was a genetic condition, and now we know it's associated with different types of variations of chromosome 21. So as genetics moves forward, we'll get a better and better understanding of how development and behavior manifest differently in different individuals. The genetic influences are never one-to-one. It's never one gene causes one behavior. They're usually multiple genes interacting with themselves and interacting with the environment. And then, as I said before, there's no clear cut between disorder and normal. They're usually a spectrum and extreme variations that continue with normal variants. And what genetics does is it makes it probable that a certain characteristic will occur, not predetermined. So for example, two individuals can have the same genetic defect, but one may manifest behaviors in a different way than the other, and that's probably some of the environmental influence. So as you can see, nature via nurture manifests so differently even if the genetics are exactly the same. As you know, even monozygotic or identical twins are not exactly the same when it comes to their temperament or their behavior characteristics, even though they share every single gene. The prenatal environment, of course, is the environment in which the baby is before being born. It's important to know this because by the time a woman knows that she is pregnant, the brain is already developed. So by the time the baby is born, there are 100 billion neurons or brain cells, and they start developing to move towards their final destinations and form connections. Now, even though this is happening so early in the fetus stage, the brain is not completely developed at birth. There's still connections that aren't yet formed, and this takes experiences with both the providers, so the mother or the father, and the environment. And so what happens, as this next slide will show, is you've got a lot of neurons present early in the prenatal period. And if you can look carefully at the slide, you can see that the number of neurons stays the same. In fact, we have less and less neurons as we get older. They soon begin dying off. But as you can see, they get very intense in their connections. In the first couple of years of life, a lot of intense connections are formed, or synaptic connections between different neurons as they send messages to one another and learn from one another. But as you can see, as we get older, these connections get fewer, and that's because we refine them. We cut away what's not necessary, and we become more efficient and keep fewer connections to do more tasks. Now, as I said before with development does not progress uniformly. Some areas are undergoing proliferation. That means there are more and more cells in, say, the language area at one point in time, and then after some time more and more in the motor area. So when we talk about what affects development when the child is in the womb, we have to know the timing of when the potential toxin or the agent can disrupt the brain. Now, the brain is not just disrupted in terms of its structure, it's more disrupted in terms of its function. You've got innumerable chemicals, hormones, growth factors that orchestrate a very intricate process of brain development. And all of our cognitive functions, our attention, our memory, our language, our socialization, and our behaviors arise from different parts of the brain interacting with one another with different chemicals. And so you can understand how intricate this is, and the smallest throw off of any one of the areas can result in catastrophic results. I'll give you examples. The maternal environment consists of either normal things like normal hormones, normal nutrition, and then toxic things that are not supposed to be there. So all of these play a role. Maternal thyroid hormone is essential for brain development of the child. So in women who have deficiency in thyroid, you can have a hypothyroid child, which is significantly impaired cognitively and developmentally. Similarly, with maternal diabetes, you can lead to several different conditions. For example, there's something called caudal regression syndrome, where the child has neural defects in the lower part of the body because the mother may have diabetes. We're all well aware of folic acid, and I'll show you in the next slide how by supplementing folic acid to women of childbearing age, we can reduce the prevalence of spina bifida. And then, of course, maternal infections can seriously affect development and brain because you've got syphilis, herpes, cytomegalovirus, things like that, the torch infections as they call it. Now, there are things that pregnant women do that can also affect development of their child. If they take illicit drugs, if they're on certain medications that may cause birth defects. We know about the famous things with thalidomide in the 50s and 60s. There's also alcohol, which is the #1 toxic influence on child development. Environmental toxins, you've heard about the warnings about mercury from certain types of fatty fish. We've tried to decrease our polybiphenol things that are there in refrigerants and in aerosols. Aspartame, which used to be a previous sugar substitute, is taken off the market because of its effects on the developing fetus. And of course, X-rays to pregnant women can cause serious problems to the developing fetus. The problems with these toxins and teratogens, what teratogens are basically interferers. They are objects or events that interfere with normal development, and they don't actually kill the unborn child, but what they do is they cause malformation or defects. And these depend on when they are during the pregnancy period and how much of a dose that the fetus receives. These are not hereditary, so if a child has one of these teratogenic effects, they don't pass it on to future generations. This is just a slide showing different times during the gestation, what organs are developed. So as you can see, the brain and the central nervous system develop the first, and then we go through the heart and the extremities, etc. So different teratogens affect the body of the developing fetus in different ways depending on their timing. So obviously you can see is if something occurs early during development, it has the potential to affect certain systems more than others, and if some are later, then they don't affect certain systems. Some examples of toxic influences are, for example, alcohol, tobacco, lead, infections, polychlorinated biphenyls, as I talked about, substances of abuse like cocaine, radiation, and then you've got some things that are actually needed, and if we don't get it, for example, adequate oxygen, iodine, thyroid, folic acid, fatty acids, etc., then the brain can suffer. So you've got a developing fetal brain that's affected by toxic substances, but also affected by lack of having normal substances. These are some of the sequelae. So we've got pictures here of different disorders, all of which are affected by a fetus's exposure or lack of access to different things. So the top left-hand corner, we've got a child who has a thin upper lip. I don't know if it's easy to appreciate, but you can see a thin upper lip, a flat what's called a philtrum, the area between the nose and the lip. We've got a small head, slightly prominent ears, triangular face. This is a child with fetal alcohol syndrome, so probably was exposed to alcohol in utero. Another one, the middle top picture, is of a child with shortened arms and deformed hands, also shortening of the legs, deformation of the feet. This is what's considered a thalidomide exposure. You've got the top right-hand one where you've got the fetus with the protrusion from the lower back, and this actually is the spinal fluid in the spinal cord in a sac, and this is what's called spina bifida or meningomyelocele. This is caused because of a variety of things. So one of the things we do know is lack of nutrition of folic acid in the mother can be one of the causes of this. On the bottom left hand, you've got a child who's got these spots all over the face. This is what's called a blueberry muffin appearance that comes with a congenital rubella. So this is a infection in a mother that can have disastrous consequences in the fetus. You can have mental retardation, blindness, deafness, seizures, etc. And the last picture is of a child who has sort of an open mouth appearance with a protruding tongue and a generalized low tone or hypotonia, and this is in congenital hypothyroidism, where there's either a deficiency of iodine or thyroid hormone in the mother, or some antibody is combating the mother's thyroid hormone and the baby's thyroid hormone. So these are examples of where the prenatal environment affects a child's development. Now, temperament is an interesting thing. Temperament are what are considered individual differences in a child that you're born with. These remain over time. They modulate with the environment over time, but some of the characteristics, there are actually 9 temperamental characteristics, and I won't go into detail, but they are activity, regularity, the initial reaction, so is that approach or withdrawal, adaptability, intensity, mood, distractibility, the persistence or the ability to sustain attention, and sensitivity. Now, these are 9 different characteristics that are basically biologically based, that modulate with environmental factors, and they interact together to cause what Thomas and Chess had talked about, their temperament types. Now, generally, there are 3 types, and I don't like the connotations that, some babies are quote-unquote difficult babies, but they're called easy babies who adjust well, establish routines, cheerful, easy to calm. And these are 40% of infants. And then you've got the so-called difficult ones, slow to adjust, negative reaction, very intense. And then you've got the slow to warm up that are difficult at first but warm up over time. And if you can see, that's 40, 10, and 15%, 65%. The other 35% is a mix of these. As you can see, the 9 characteristics can interact in different ways with each other and with the environment. So you've mostly got all these different variants. But temperament is something that you remain with. And I don't believe temperament is as important as the goodness of fit, which is the interaction between the child's temperament, which generally remains throughout their life, and the environment. And the environment can be the social environment, so family members influencing the child's temperament and modulating them by how they react to the child. You've got the physical environment, and this dynamic is always mutual influence. As we had seen in that earlier slide with the adoptive family, you've got bi-directional influences, a child influencing the family influencing the child. And so this is what probably accounts for different children in the exact same environment but have very different personality traits. It's how they interact with one another and how they interact with the environment. Now, the environment we've talked about a lot, and it really plays an influence. Whether you're North Dakota or New Delhi, the environment is a critical component to helping you express some of your genetic characteristics. The environment always starts at home with the microenvironment. When you look at systems-based models, the family is the first system that a child interacts with. And there's a dynamic interplay not just with the child and the family, but also between family members. You've got family factors influencing child development include how parenting styles and child rearing is done in this family, the cultural factors, the socioeconomic factors, and transgenerational. You've got a lot of families with multiple generations involved, and we'll talk about that in a second. Birth order. Now, there had been a lot of questions about birth order. In the past, Sir Francis Galton believed that only firstborns, reach prominent positions because he did a study and said that it's more than what can be attributed to chance. And then Adler had the theory that depending on your birth order, your characteristics are different. You've got authoritarian firstborns who are competitive, the middle one who feels squeezed out of privilege, the youngest who's just babied and is less of an achiever, and then a singleton or an only child who tends to have a high ego but is neither spoiled nor a high achiever. Now, the issue with birth order is it has never been shown to affect development per se, but it is an important factor for sibling relationships. And a recent study actually showed that it is not the birth order per se, but a social order in the family. And there's a very interesting study in Journal of Science in 2007 where they looked in a Scandinavian country at not just the birth order, but also where there had been deaths along the way of, say, the firstborn or the middleborn, whatever. They found that it's the hierarchy or the social order in the family that sort of correlated with IQ scores. Now, this is not a very perfect study. Real IQ tests were not given to these individuals. What was done is they have the standardized test at 18 when they go into the military, and they sort of correlated that with things like Wechsler scales and stuff like that. So it's not actually a prospective study doing IQ tests or doing serial cognitive assessments. It's just a correlational study, one time done, and sort of looking at the birth order. So it's interesting, but I don't think much causation or association can be drawn from it. Parenting styles. Now, talking about parenting styles, Diana Baumrind had excellent concept about how parenting styles influence different styles of behavior in children, because parenting itself is a very complex activity. It's not just, oh, this is parenting. When you talk about a specific practice, reading aloud to children, how you discipline children, that's not as important as a general sense of how a parent interacts with the child. So the broad pattern of parenting is more important than specifically if somebody times somebody out or reads aloud to a child. And so, this complex activity is interesting because, there are two elements in there. One is, of course, how a parent responds or is supportive to a child. So the extent to which they're available, they foster individuality and assertion by the child. And then the other aspect is the parent's demandingness or the control. So how the parent helps to mold the child by their different efforts so that they help the child integrate into the family. And what was found is an interesting table where if you take on one end the responsiveness, so if you look on the x-axis the emotionality or the responsiveness, and then the demandingness or the control on the y-axis, we can come out with these different boxes. You've got two styles of emotionality or responsiveness, the warm responsive ones and the rejecting unresponsive ones. And then you've got the two types of control. You've got the restrictive or demanding type and the permissive not demanding type. When you look at it, McCabe and Martin had actually found that there are different categories of parenting styles based on these traits. You've got the parent who is warm and responsive and yet maintains some control and is demanding, and that's considered authoritative. And then you've got the rejecting unresponsive parent who is also very restrictive and demanding, and that's authoritarian. Now you've got the warm responsive parent who really doesn't do much, just permissive. And then you've got the worst type, which is the uninvolved, is not making any demands, completely permissive, and yet, is not responsive to a child's needs, completely rejecting. So, as you can tell, there are different consequences depending on the different parenting styles. Authoritative parents tend to produce children who are more socially competent and instrumentally competent, whereas the ones who are uninvolved, as you can tell, perform the most poorly. The children and adolescents perform most poorly. And this is actually studies that were done looking at different parenting styles and the consequences. The children from authoritarian families tend to do well in school, don't have problem behavior, but they have lower self-esteem. You can imagine being beaten down all the time emotionally. And they have poorer social skills and higher levels of depression. And the indulgent ones, or the ones who are permissive and yet responsive, they tend to have more problem behaviors and perform well lesser, but they have higher self-esteem, better social skills. So you can tell that there are different patterns of child development and behavior depending on parenting styles. Bonding and attachment is an interesting thing, because bonding is basically what you do to develop an attachment. And basically, Bowlby and Ainsworth's work on this, you've had a lot of wonderful studies with the sock puppets, and you've got the little wire monkeys, and we won't go into details, but those are fascinating studies talking about how people imprint. And you've heard about the stories of, the geese following the little propeller or the pedaled airplane, and, the chicken comes out and sees the first thing, and that's mama. So bonding and attachment is interesting. It's genetically predetermined that we form attachments. Now, what is interesting is that is driven by a sense of survival, is that an infant needs to form an attachment to have its basic needs met: food, clothing, shelter. And so, maternal response is crucial to that, and people believe that when an attachment forms is really important. There's this so-called window of opportunity that, if you don't bond within the first so many hours of life, that's it. That's not really true, because we have seen that even though there have been missed experiences, neglect, and kids in orphanages, that doesn't necessarily mean you'll have poor outcomes. Yes, they can have reactive attachment disorders, a lot of problems, but they can form attachments. The attachments may be not optimal, but there is the capability to form them. And of course, Ainsworth's study, where had the mother in the room and interacting with the kid, and then leaves the room and comes back. How well do kids respond depends on how attached they've been. So, for example, the securely attached ones get really upset when the mother leaves the room, and then when the mother comes back, warmly greets and seeks comfort. And then you've got the children who haven't formed secure attachments. They've either formed insecure avoidant ones. They basically ignore the mother when present, and they don't show much distress and turn away. You've got the resistant ones who are very distressed upon separation, but ambivalent and angry when the mother returns. And you've got the disorganized ones who have had really poor attachment. They're very confused about the whole thing. How should I react when mom leaves? How should I react when she comes back? So you've got these different patterns. It's fascinating to look at videos of these studies, because they're very painful to watch. You watch the mom creating what's called a stone face and not responding to the child, and how the child begins to react to that. But it just goes to show how secure attachments are really important for a child to develop trust and interaction with the parent figure. Now, what has attachment got to do with developmental outcomes? Well, attachment theory shows that secure children tend to have more autonomy, more able to regulate their behaviors, less likely to have behavior problems, better social relationships, and insecure children, by contrast, have more problems all around. And so I want to make reference to an excellent publication. It's the World Health Organization's publication in 2004, and it was titled Family and Community Practices That Promote Child Survival, Growth, and Development. And we'll put a link to this PDF file that's available full text on the web. And this is a fascinating thing, because it really talks about the efforts the WHO has made in obtaining evidence-based practices, and it pretty much is another publication just like the From Neurons to Neighborhoods that I talked about, that will also be downloadable for you, that a lot of these data is from. So a lot of child development data can be had from some of these wonderful organizations. It'd be really nice if you all could read and look at what's happening around the world. Getting back to the presentation, the family characteristics that are important that influence child development. We'll go through some of these, but what they are the marital status, family size, parents' education, financial situation of the family, the strength of parents' relationships with one another, and the parents' mental health. we do know that stress plays a very important role in a child's development. So a family stress model where, and this very often comes up in divorce, separation, and marital conflict, is that the studies have shown that marital conflict is more likely than any other family variable to have an adverse effect on children's development and outcomes. Because you can imagine is that separation and divorce is stressful time for all family members, including the children, the parents, extended family. But what happens is at this time, the children are in the greatest need of emotional support because of what's going on. And yet, that's the time when the parents are least capable of providing it. So you've got stress that disrupts parenting, that leads to poor child outcomes. The socioeconomic issues are humongous because you've got different factors. You've got parental work status, you've got family income, the education, which again plays into socioeconomic, because as we know, is the higher educational level achieved, the greater is the potential for family income and the family structure. So let's talk about some of these socioeconomic factors. Different socioeconomic strata, because of education, income, and occupation, create different opportunities. Families with higher capability to provide safe housing, nutritious meals, higher quality childcare, learning opportunities generally provide better outcomes. And this is not because families do not want to provide it for their children. It's because they're incapable based on their socioeconomic status. The psychological well-being of mothers and their associated patterns of parenting are also likely to suffer in families with limited resources. You can imagine that mothers who are working 2 jobs, who are overwhelmed, have less ability to maintain their own mental health and therefore less ability to create positive, nurturing environments in their homes. What has happened over time, and we can see this from the Neurons to Neighborhoods publication, is that the employment of parents has increased dramatically over the last quarter century. From having in 1975, you could see that about 25% to 50% of primary caregivers used to work, and now it's up to 50 to 80%. And so what happens is that more and more time is spent in employment, and parental employment often but not always entails supplementing parental care with substantial amount of care with others. We'll talk about that in a minute, about child care out there and what happens. So with discretionary income increasing, there also are work-related expenses. So a stay-at-home mom is not going to spend money on child care. You'd think, a working mom is going to be able to provide better for a child, but a substantial portion of that is going to go in childcare, transportation to and from childcare, and so we've got that employment and income doesn't, correlate to a one-on-one improvement in child outcomes. Most children are generally positively affected or generally not affected by maternal employment, except we know that if early in a child's life, the first year of life, if mothers work long hours, that actually has a negative effect. Now, low-income children generally benefit, but medium-income families, if the mother is working very long hours early in a child's life, that is a problem. And again, this is studies that have shown that. Trends in parental employment depend on the type of work, the type of income, the amount of income, the nature of the job in total hours. So it's more than just a working mother is better off than a stay-at-home mother. And I use mother broadly. This is single fathers, dual parent families, etc. So, but for the purposes of these studies, they mainly studied mothers. Interestingly, poverty is one of the biggest impacts because you think we are a quote-unquote first world country and poverty is something that affects third world countries. Well, you have to understand that currently in the United States, there are 36.5 million people below the poverty line, and that includes 12.5 million children under the age of 18. 12.5 million children in the United States live below the poverty line. And the poverty line is defined currently by the U.S. Census Bureau as an income of between $16,000 and $20,000 a year. And this is a 2-child household, 3 to 4 member 2-child household. So this is an issue that exists in our country today. And what happens is that there are consistent association with studies between economic hardship and compromised child development. And what happens is that as children get older, generally family incomes increase, and this could be because there's less amount of money spent on the necessities for smaller children, diapers, baby food, etc. But also what happens is that the parents are more likely to have employment once the child is out of the early critical stages. Now, welfare reform studies have shown that if you don't improve the home environment, the parents' mental health, parenting skills, increase in family income in themselves do not do much to improve child outcomes. I'll give you an example of how poverty can have devastating effects on child outcomes. When you look at poor related to non-poor children, the risk of adverse child outcomes for lead poisoning is 3 times. For having a hospital stay is twice. For having a learning disability is 1.5 times. The likelihood of child abuse is almost 7 times. Depression. So these are what are called risk ratios. So as you can see is that poverty increases stress on families and increases the association and the risk of having negative outcomes. What about parental education? There have been good association that greater parenting education, better child achievement and behavior. However, that could just be an association of parents with higher education have better literacy environments in their home, better teaching and parenting styles, and use their resources to invest in better child care, better educational materials, etc. But we haven't proven that if we take a parent with, say, a lower education level and do adult educations and move them to a higher level, whether that actually benefits. This would be a wonderful study to do, is to say, take somebody who does not have a college degree, look at their child outcomes in those families, and then if we teach them and give them a college degree, does that necessarily improve child well-being? But parenting education obviously leads to better opportunity for children, that we know. Now, parental mental health plays an important role too, because you've got this bidirectional influence. Families where parents suffer from mental health conditions have greater difficulties with parenting, and therefore their parenting styles sometimes can be less than optimal and cause greater behavioral issues. But then you've got children with developmental behavioral problems that cause greater emotional distress and can actually lead to parental mental health issues like depression and anxiety. We see this all the time. Families with significant disabilities in their family, you've got parents with greater stress, and you've got parents who have emotional disorders, and it's the chicken and egg thing. Is it because parents with mental health issues have had less than optimal parenting styles, less than optimal opportunities for children, leading to child behavior problems? Or is it the child with a genetically determined developmental behavioral disorder that's influencing the parents and causing them to have mental health issues? So as you can see, the bidirectional influence is all over the place. A family structure has also been studied, and its influence on child development. On an average, child raised by single parents have lowest levels of social and academic well-being. But we don't know if single parenthood is likely to, via its effects on lower income and less parental time, to have effects rather than just being a single parent. So, a lot of these outcomes, the lower outcomes in single parents, is not because a single parent is not competent as to a two-parent family. It's because probably they're spending so much time in providing for this family, they have less time to spend in quality time with the children, and they have less discretionary income. The cultural factors also play an important role, and it's stunning because, we've had cultures for centuries, and cross-cultural perspective has only recently been incorporated in studies. Most of the studies out there on child outcomes and behavior and development generally deal with, the cross-cultural transmission of symbolic beliefs and rituals. And it's basically, what expectations are brought to the table by different upbringings, what values, what spiritual and religious values are out there, or discipline roles or gender roles. For example, there are certain tribes in Africa where, the coming of age rite includes, going out and being by yourself in the forest and holding your own. Some people And then in the case of the Amish, you have where the coming of age or rite of passage is when they separate from their nuclear family and set out in the world. And so you've got these different types of practices and beliefs out there. And these are important because they play a role and we have to be sensitive about it. Today in the United States, as you can tell, there has been a tremendous shift in the demographic patterns. And there's a strong feeling that, non-native Caucasians will probably be a majority of the population over time. So as the population diversifies, we have to be aware of the different cultural perspectives brought to the table. An example is sleeping routines. For example, in the United States, we value autonomy and independence, and we expect our children from a young age to sleep away from the parents. But this is not true in other countries. There is a lot of interdependence, and children routinely sleep in Asia, Africa, and Latin America with one of their parents, even when separate rooms are available. So it's not a question of access or opportunity. Now you'd say, well, we're an industrialized first world nation, where in Japan, children also sleep with their parents. So this is a cultural perspective that we need to be aware of, and this really plays an important role in how we as pediatricians speak to our parent clients. When they come in, they talk about co-sleeping. We first have to be sensitive to their cultural perspectives towards co-sleeping. We should not enforce on them, well, it's not normal for your 4-year-old child to sleep in your bed, if it's culturally accepted in that family. Transgenerational factors play an important role. We have seen over time is that more and more grandparents fulfill the roles of primary caregivers, and even if they're not primary caregivers, there are a lot of blended and extended families living together for social and economic reasons, and it's their influence in the family that's also quite powerful. It could be a direct influence where they assist in childcare and they live in joint families, or it could be the indirect influence is basically in the influence in the parents of the children, how they have disciplined and raised them, then gets translated over into how parents discipline and raise their children. There's a lot of myths and beliefs. So for example, you have some grandparents and great-grandparents who believe that ADHD does not exist. It's not a genuine disorder. It's just poor parenting style. If you just whoop him, everything will be fine. And so this plays a lot into how some parents approach it. There has been a shift that there's been more and more evidence that parents are willing to accept that ADHD is a genuine neurobiological disorder that requires treatment, and it's not merely a result of poor parenting practices. So that's another way how transgenerational passage of myths and beliefs mold child development. And the family's meso-environment is the extended family, the village. So you've all heard about Hillary Rodham Clinton's book, It Takes a Village. Well, very few people know that she took that title 2 years before. It was written by Jane Cowan Fletcher, who had talked about how it takes a village to raise a kid in her studies that she had done in Central Africa. In West Africa, in Benin, when she was part of the Peace Corps. And so the meso environment is the extended family. Childcare plays an important role too. The childcare second to the immediate family is the context in which early child development unfolds. Still, in the United States, parents and relatives continue to provide most of the early child care, but there has been a rapid growth in paid care by non-relatives, either in center-based or in home-based settings. And there have been beneficial outcomes to this, provided childcare is what's considered high quality, and we'll come to that in a second. Now, the reason childcare is important is because it provides a number of opportunities to children in certain environments that they would not get anywhere else. They have learning opportunities to be around other children. They're getting prepared for school life. It provides support for working parents. It's a respite for certain situations. For example, in neglect situations, it provides an opportunity while the child is not in their home environment, while they're in foster care. It provides for them to be around other peers and develop typical experiences. And it also, thanks to several federal funds and titles set aside, provides access to supplemental services. Vision and hearing screening, feeding programs, developmental testing opportunities are available in certain childcare settings. this is taken from the 2005 Census Bureau, and it shows that basically there are, for childcare settings, there is about 60% of children are in some type of childcare setting under the age of 5. And most of this is still relative care. It's immediate family or extended family. But 30%, 34% of this is in non-relative care, either in an organized facility or a daycare center, nursery or preschool, Head Start, etc. And when we look at these, you can see that for younger children, it's still in immediate family and relative care, and mostly in the home, either nanny or babysitter. But this proportion dramatically increases to about 45% is in center-based care, while still the majority is still family-based. You can see how much child care settings plays a role in early childhood opportunities for development. Childcare and development, the reason it's important is because the effects of childcare is generally neutral unless it's very early. If a mother goes back to work too early and throws her child to childcare for extended hours and it's a childcare of very dubious quality, then there's negative influences. Otherwise, childcare effects, when looked aside of parent effects, they have very little role to play. The link is as positive as it is negative when looked at the mother-child relationship. An example is this is, childcare can protect a child when there's poverty, mental health issues in the family, high levels of family conflict. But it compounds risk. For example, child who are growing up in supportive environments, if they are thrown into childcare for extended periods of time, it takes away from that positive building between a child and a parent. So the important issue is high quality childcare, and this is actually defined. And there are many criteria. I've only outlined a few. High quality childcare has been associated with positive outcomes. And how do you define high quality childcare? Well, it depends on the childcare provider's education, specialized training, the ratio of caregiver to child, whether they are retained in the environments, adequate compensation. And as you can tell, there are very few ways to measure this. I mean, certification or a license does not necessarily mean high quality. And there have been numerous issues where spot, inspections have found numerous violations, but we're also talking about retaining quality childcare providers. It's a high burnout area, as you can tell, and many people do it as a stepping stone to their degrees, to further things, specialized education, becoming independent contractors. So high quality childcare is in great need, but in short supply. And until we get some sort of universal access to preschool programs, we do run the risk of having children exposed to a variety of different childcare settings. Now, childcare and behavior, it's interesting because there were studies recently which showed that the more time that children spent in childcare, the more assertive, disobedient, and aggressive they get. Now, you have to understand that these studies showed that these behaviors, while they were quote-unquote more assertive and aggressive than their non-childcare cohorts, they had normal behaviors. So it just shows that children who are probably exposed to, other children and have to defend their turf tend to be more assertive than children who are not exposed to this. And this link that was there was found across family backgrounds, across types of childcare, and it found that, better quality childcare, obviously, less behavior problems and lesser quality childcare. But this was an interesting study because people said, childcare is not good because it makes children more aggressive. But that's not true. It doesn't make them more aggressive in a pathological sense. It made them more assertive and aggressive than their cohort who was not in childcare. Now, the neighborhood, part of the meso environment, one of the things that were done, most of the studies on neighborhoods are done in what are called high-risk inner city neighborhoods. And so obviously issues about neighborhood violence comes into play, hazards in the physiologic environment, lead poisoning, drug exposure, things like that. But what has been found is that neighborhoods are more like than they are unlike each other. The differences are between families in neighborhoods. And so you've got different families with their microenvironments will be different, even though the neighborhood is the same. Now, obviously, dangerous neighborhoods have negative influences because it restricts children's interaction with peers and adults and can be physically hazardous to children's health. The support system for the family is important in these neighborhoods and also extended families outside of these neighborhoods. The more supported families are, the greater influence it is on child's development. And the reason is they form buffers for parents at times of stress. For example, marital conflict, economic stress. If you have a family support network, it tends to mitigate some of these factors. It doesn't take them away, but it does reduce the effect that it has, because you can have a child who goes to an extended family member for respite and therefore reduce opportunity for exposure to conflict in a family. Coming to some of the other environmental effects, but we're moving to some of the more micro effects: nutrition, health, medical issues. So this is intrinsic. And nutrition is critically important. When talking about nutrition, the important thing is to look, as I talked about earlier, with timing. Timing in terms of the prenatal is important because as the brain begins to develop, it first, as you know, creates a bunch of different brain cells or neurons, and then later it forms connections and matures. So if there is deficiency of nutrition earlier in the second trimester, it leads to fewer brain cells. If it's later in the third trimester, that leads to lesser maturation and glial cells, which are the connection cells. So the timing in utero is important, and then after birth is the first 3 years are what are considered the critical period or the vulnerable period, because that is when, as you know, the connections get formed with the fury, a lot of maturation occurs, and then later on in life only the pruning and the sophistication occurs. The longer the malnutrition continues and the earlier it occurs, the greater the effect on the brain. But children have been shown to be remarkably resilient. They recover even after being quite malnourished. If they are given the right nutrients and they are fed appropriately, they show remarkable recovery, and that's part of the plasticity of the brain. However, the link is not just you eat something, you develop better, or if you don't have something and you supplement it, your behavior gets better. It's far more complicated, because what these nutrients do is they help to create some of those microchemicals, the hormones, the transmitters, and so there's a very intricate interplay between nutrition and the brain, and what happens is that there's a lot of adaptation also. Nutrition can affect brain by either affecting the number of neurons or the size, or the physiological changes, how someone feels and how they behave, and then their behavior affecting their performance. One of the extreme forms of nutritional deprivation is what's called failure to thrive. And in children, failure to thrive is defined as being less than the 3rd percentile for body weight for your age. Now, generally, failure to thrive is common more in low-income children, as you can imagine, probably lesser opportunity for quality nutrition. It's interesting that in our society, the cheapest foods are the least nutritional foods. You can get a Happy Meal for $3, which has nothing but calories and carbohydrates and some protein with little to no, iron and vitamin C and things like that. And if you really want quality fruits and vegetables, they cost a ton of money. More common, of course, in children who are low birth weight, who basically start off at a low weight, or start off with a earlier than expected, or with small for gestational age. So premature, small, gestational age. Children who are substance exposed, children who are exposed to opiates and cocaine and marijuana and alcohol in utero tend to have failure to thrive. Developmental delays also are a problem, and children with special healthcare needs. And the reason these children have greater failure to thrive is because A, they have less coordinated feeding patterns. B, they burn a lot of energy. For example, children with ADHD burn a lot of energy running around, hyperactivity, so they consume their calories rather than storing them for growth. In both the US and in developing countries, and we've had wonderful studies done. Maureen Black has done studies in India and the Philippines, and we've had studies in this country where there's a relationship between failure to thrive and a lower IQ, and these have been found in a variety of countries. And basically, these effects don't just last for a couple of years. They can last well into the school years, affecting academic performance and cognitive performance. So basically, malnutrition goes beyond just the first 3 years of life. You may be eating really good, but you may be missing out key micronutrients, which we'll describe. And these micronutrients are important because they help both in the cognitive development, but also in what's called the executive functioning, your frontal lobes, how you deal with stress, how you organize, how you pay attention, how you shut out non-essential components. And some of these nutrients, like for example, iron and omega-3 fatty acids, have been found to be important for frontal lobe activity. Some of the micronutrients are iodine, iron, zinc, and vitamin B12. And they're reported to, their hypothesis is that they have a direct effect on the neuroanatomy and the neurotransmission. Now, it's possible that, the behavior a child exhibits, with these deficiencies further alters, remember that famous bidirectional effect. So let's say a child who is iron deficient. What do they have? They have anemia. What does anemia cause you to be? Be forgetful, to be a little hyperactive, to be impulsive, to have slow learning. Well, can you imagine a hyperactive kid is probably going to change the way a mother reacts to the child or a caregiver reacts to the child. They don't want to take the time to feed the child who's running all the place. They put the plate, they say, you want to eat, you eat, you don't want to, you don't. Well, child may not eat much, further compromising their nutrition, further compromising their development. So you can see this is a sort of a vicious cycle that gets hard to break unless you hit the root cause. Iodine is one of the the iodine deficiency is one of the most preventable causes of mental retardation in the world. And this is prevalent predominantly in areas which don't have access to seawater and the iodine that comes off certain plants and seaweed and kelp, etc. So mountainous region, floodplain regions, etc. Now in this country we've been very fortunate by a tremendous public health initiative which has caused iodization of all salt. So you get salt which has iodine in it, and we have salt in our diet all the time, and so this has been very effective in reducing the prevalence of congenital hypothyroidism. Remember going back to that picture of the child with the hypotonia, his tongue sticking out? Well, that's congenital hypothyroidism, and it still exists in places in this world where there's no iodine in the diet. Now, generally, if this deficiency occurs in utero, it can cause irreversible neurological and cognitive deficits. So the concept is to supplement early in the pregnancy. Don't wait till the mother is iodine deficient. You've got to supplement it early and then have better outcomes. Now, if the iodine deficiency occurs after the child is born, you can still have some of these symptoms. These children may have genetic defects which doesn't absorb the iodine well, doesn't incorporate into their body, into their cells. And so, these cognitive deficits have been noted, and basically children who even have had correction of these deficits and have mild hypothyroidism can continue to have some academic deficits, not really big cognitive deficits, but academic deficits over time. Now, one of the problems is, of course, iodine deficiency can occur in areas where there's poverty, and we already talked about poverty being a powerful influence on child development. So again, you've got these commingled and meshed factors that predominate, and one does not necessarily exist in isolation of the other. Iron deficiency. Iron deficiency still is very prevalent around the world. In fact, as a single nutrient disorder, 20 to 25% of all babies worldwide, these are older studies, but still, are affected by iron deficiency. In the US also, you have a high prevalence of iron deficiency in certain populations. The immigrant population, Hispanic population has shown a higher prevalence than the Caucasian population. And again, this is not because, Hispanic populations tend to not feed their kids. They have different practices. Think about cultural perspective. They have found that they can cook in non-galvanized pots, which can cause greater leaching of lead and other confounding, interfering nutrients. They can have different nutritional strategies depending on what cultural perspective they bring to the plate. They have different patterns of breastfeeding, and we know that after the 4th month of life, you have to supplement iron because the mother's breast milk is deficient in iron after 4 months of age. So by fortifying infant cereals, infant formula, we've got away from this, but still poor and minority children still are at a risk for iron deficiency in their children. And iron deficient infants can have lower cognitive and mental development and motor development, as can be seen in some of the Bailey studies that were done, but also can have fatigue, fearfulness, weariness, and so behavioral differences are also noted. Now zinc is an interesting thing because basically what has been found is that zinc is an important component of several enzymes that involve the GI tract and dietary and digestion, also where they've been found to be involved in neurological factors. But however, the studies out there have been inconclusive when it comes to zinc supplementation. Can you really improve cognitive and motor development is hard to tell. Some people suggest that zinc supplementation improves activity and motor development in the most vulnerable infants. That's more in black studies. So the jury is still out on whether zinc is a critical component, but we do know it plays an important role in multiple systems. So one of the things, if we go back there, is in terms of zinc, is an extreme deficiency of zinc is what's called acrodermatitis enteropathica, and that is seen in children who've got cracking and blistering around their lips, on the tips of their fingers, tips of their toes, and this can be seen generally in kids who have some deficiency. So for example, malabsorption syndromes, where they actually have lost part of their gut after surgery when they were neonates, and I've seen kids who have got these there's enterostomies, get fed by a feeding tube, but they've lost up to 4 feet of the intestine, and that's the section where the absorption of zinc occurs. So it doesn't matter if you give them zinc by mouth, it's not going anywhere because it won't be absorbed. So yes, zinc deficiency can occur not just if they don't get enough, if they have medical problems that cause them to not absorb enough. Lead is by far one of the most prevalent things in certain societies. We've come a long way in our society from having lead prevalent because we have unleaded gasoline now. We have had lead-free paint for many years, but if you have a wonderful old home that's 100 years old and you decide to remodel it, well, you're going to spew lead paint and dust into the environment. And the reason lead is a big problem is because there have been consistent studies which show cognitive functioning declines with spikes in lead levels. And currently, we want to keep lead levels under 5 micrograms per deciliter. And this is why we will test lead levels in children at 1 year of age, and if we find it greater than 5, then we will retest it, and we want to make sure that it's not significant. There have been a lot of studies which show lead also affects behavior, distractibility, impulsivity, hyperactivity, poor organization have been seen in children with higher lead levels. And they actually did a study amongst the inmate population in a Philadelphia subsample of the CPP. They found that a history of childhood lead poisoning was a strong predictor of adult criminality. Of course, you can't say that every child with lead is going to be a criminal, but since it affects cognitive functioning and it affects your impulse control and your attention to detail, obviously you're more likely to get into trouble if you're not processing well enough and you're not paying attention to cues in your environment. How lead gets into your system is basically young children explore the environment and they have a hand-to-mouth activity that leads them to take in more lead. And children with nutritional deficiencies of zinc, of iron and calcium are at greater risk because the body tries to supplement one metal with another. They say, I haven't got enough iron, let me get some lead. And what happens is that these are irreversible damage. If a child's developing nervous system, if lead hits the neurons, just if you get rid of the lead is not going to make it better. We are trying to keep children's blood levels as low as possible, but some people believe that even less than 5 is not good enough. We've got to get it less than 2. Housing. Now, that picture up there in the top left-hand corner is currently, the most expensive house in the world, Bill Gates' house. But that's soon going to be supplemented because in this will interest you all. In Bombay, in India, the one of the richest men in the world is building the richest residence, the most expensive residence in the world, $2 billion house. I think it's a 14-level home, and he's building it right in the middle of the number one slum of the shanty town in Asia. And so that goes to show, in the midst of abject poverty, you've got the most expensive house in the world. So anyway, getting back to housing. Housing does affect children because the child's ability to thrive can be greatly enhanced by their surroundings. And factors that influence housing is if you've got a child who's exposed to inadequate housing, or no housing, as in a homeless child, or multiple housing moves, or moves from one home to another in the context of multiple placements, divorced and separated families, this can affect their development. So inadequate housing, if you've got housing that is not maintained well, that has got walls crumbling or poor sewage drainage, etc., this can cause a problem because A, you've got risk of mold, causing child to have access to these pathogens which increase the risk for respiratory illnesses and asthma. You've got exposure to lead paint and peeling paint, which causes lead poisoning. You've got mold allergies. You've got injuries from unsafe conditions. And these are problematic because, generally the type of families in these type of environments, the families again affected by poverty and low income levels. And when families live in neighborhoods of poverty and inadequate housing, there's greater risk for involvement of criminal behavior and drug use because the role models and the stabilizing influences are less than optimal. Homelessness is the extreme manifestation of poverty, and I actually have had a couple of patients who have been in homeless shelters. And the problem with that is studies have shown that homeless children are twice as likely to have health problems, to go hungry, to have greater rates of developmental delay and academic malachievement, and greater risks of behavior problems, depression, and anxiety. So this is an extreme issue. It does occur. It occurs in Lexington. I have had children who have been in homeless shelters in Lexington while their families are going through economic hardships. So this can also seriously compromise child development. Multiple moves, families move, and they move for economic reasons, for family reasons, for personal reasons. And what happens is that one is, if a child keeps moving, then their doctor keeps changing, and there's no one site for coordinated healthcare. So what may happen is that information may not be transmitted, a child may not get the adequate healthcare they need. Frequent changes can cause a child to have risk for problems because their academics may suffer. You can imagine moving from one school to another in the middle of the year, missing out on academic instruction. Behaviors may change. Child who is stable in one environment ripped out, put into another. Emotionality, they go through these multiple placements. Children like stability. They like control. They do not like the unpredictability that comes with multiple moves. The health may be a problem because a move may not be for the better. A family may downsize. A family may move from a better environment to a more risky environment. So these do affect children. Safety is a very important thing because you can imagine that children are going to explore the environment. They want to be able to explore, but they don't understand causality. A child who's crawling around doesn't understand, oops, if I crawl and I touch that electric socket, I'm going to get shocked, until they actually get shocked, which is what you don't need. But, this is an important issue that we have to provide at least basic safety for children to optimize their development. Let them feel comfortable in exploring their environment, knowing that we have taken away the dangerous things from their environment. Developmentally delayed children and children with communication disorders and impulse control disorders are at greater risk for safety issues because they're not processing danger in the environment, and even if they do process it, they're not paying attention to it. And areas of safety that we have to be aware of are the home, and then the immediate surroundings, your meso environment, like the neighborhood, the school environment, getting from home to school. And of course now with all the amenities we provide our children, we have vehicles, which also are areas where they spend time. So vehicular safety, and now their ATVs and their ride-on toys, their recreational safety is something we have to pay attention to. So home safety, we've talked about the home being safe, housing, and we've talked about don't have walls crumbling around you and mold growing in the basement. In terms of what we can do is we can make sure that we keep the children safe from cigarette smoke. Obviously, don't smoke at all, but if you have to smoke, smoke outside the home. So smoke detectors from fires, carbon monoxide detectors, the silent killer, people who have furnaces which spew carbon monoxide. A smoke detector does not pick up carbon monoxide. It's important to make sure that we have these in children's homes. Guards on stairs, on doors, on windows, door locks so kids can't get into grandma's medication cabinet, can't get into where you keep your gun, where you have the kitchen knives. Storing safely firearms, if you have to have a firearm, store it under lock and key, store the ammunition separately under lock and key. A lot of people have swimming pools and have access to water, even a bathtub. You have to make sure that when you have a small child that you shut the door of the bathroom, make sure that the swimming pool is surrounded by a gate which cannot be opened easily by a child. But none of this is a substitute for adult supervision. Just because you've got a child in a house which has got door locks and plug point covers doesn't mean you leave the child in the house and walk out and come back after 2 hours. Personal safety, seat belts and booster seats. It's interesting that Kentucky has a mandatory seatbelt law, and it also is considered a primary offense, so they can pull you over even if you're not speeding and ticket you for not wearing your seatbelt. And this applies to adults. They have a mandatory child restraint law, which means that children under 40 pounds must be in an approved child restraint seat. The booster seat bill has been in Congress, in the Kentucky legislature for a long time, and it only just passed a month and a half ago, and it'll go into effect on July 14, 2008. And what it states that children who are older must be in the booster seat, so more than 40 inches or more than so between 40 and 50 inches in a booster seat, and who are taller than 50 inches. Basically what it means is that while it's important to have it, you will receive a $30 ticket if you don't have it. And there has been some concern because if a family shows that they are going to be purchasing one, or they've actually got one, they didn't bring it, they can actually contest the ticket. So it's a very interesting concept that it's a law, but it has some loopholes. This is important because not just with the booster and the seat belts, we have to think about the recreational vehicles. There's been a lot of deaths recently. In fact, in the last 1 month, there were 4 deaths, now that summer has come about, of children across Kentucky who fell over or had an accident with their ATVs, not wearing a helmet, and sustained a lethal head injury. So wearing helmets, riding and wearing protective gear for bicycle and for ATVs is essential too. Coming to medical problems, we had talked about earlier the child who, despite having zinc in the diet, did not absorb zinc because of a medical problem. Medical problems are important because they can affect development too. You've got the acute medical illnesses, you've got chronic conditions, hospitalization, surgeries, and trauma, as well as medications, all of which affect children's development, and we'll see how. Every illness, no matter how quote-unquote minute we think it is a major stressor for a child. Minor illnesses and their management, so for example, a child has a little cut, little bruise, gets a sore throat, gets a cold, these don't cause significant problems in children. Now, if a child has, hospitalization or an illness, it may cause a short regression in, say, sleep. They may be more fearful to go asleep. They might want to sleep in their parents' bed when they were previously in their own bed. They might begin wetting the bed again. They might seem to be very, quote-unquote, helpless. But they don't have any major issues and almost never affect things like social, motor, or language. Chronic illnesses are a different matter, however, and chronic illness is defined as greater than 3 months of illness that affects a child. There are 3.25 million children in the U.S. who are affected by chronic illness, and some examples are cystic fibrosis, sickle cell anemia, asthma, ADHD, cancer, things like that. They really affect children, but their effects depend upon what the condition is like, what the child is like, and what the family is like. So again, you've got this dynamic interplay that's important to be aware of. So characteristics of the child. One, of course, is when did the condition begin? When did the condition begin? Was it at a younger age? Was it older? What's the child's temperament? Easygoing child, adapts easily, or has more difficulty adapting because they are slow to warm up? What is the child's ability to cognitively process their illness? Do they understand what's happening to them? Are they able to process it? What is their self-concept? What do they think of themselves? Do they have a positive attitude towards things? What is their developmental level? So many things that the child has intrinsically will change the way a chronic illness's course affects their behavior and their development. Now, what about the condition itself? Is it a stable condition? Is it predictable? Children do not like unpredictability. So if they always go in for their doctor's visits once a month, it's much easier than an unpredictable illness that will throw them into the hospital, without explanation. The other thing is its prognosis. Is this an illness with a good prognosis, or is this one with a bad one? How does it interfere with mobility? This is very important to kids. They want to be able to move around. They want to be able to go places. If they're going to be confined to a wheelchair or at home or in the hospital, this has more an effect of them. What about normal activities? Is their illness going to interfere with them getting around with their peers, getting to school, learning? So these are all things. The condition itself, asthma, for example. Asthma, if it's very severe, might affect a child's ability to be very athletic or in sports. How important is this to this child? These are the types of things that will play into how a child adapts and how a child develops depending on their chronic condition and how visible it is. There's some adolescents who are extremely concerned about their appearance. Does this condition manifest itself physically? Is it evident in their appearance? So it may not seem like a big deal to adults, but it is to teenagers. And academic effects. Does it affect a child in terms of their functioning in school, how they perceive themselves? Is it going to hinder their moving on to the next grade? Family characteristics are also important in molding how a child changes their behavior, their developmental trajectories based on their chronic illness. Do they have a family support structure? How do the parents react to a diagnosis and adapt to its chronic implications? I'll give you an example. Many years ago, I was taking care of a child with terminal cancer when I was a pediatric resident. And the child, she was a 16-year-old girl, was very much at peace with what was going to happen and that she was probably going to die. But the mother could not adapt to it. She was very aggressive. She would have emotional outbursts often in front of the child, and it was the child trying to calm the mother down. So we saw these different dynamics present in families, and it was not wrong that the mother did what she did. That's not a pathological response. It's just you can see the child maturing much faster and sort of taking over the mature role in this dynamic when they see that the parent is losing it. The family's ability to deal with conflict and stress, that's exactly what I pointed out just now. So these characteristics of families do play into it, and siblings play an important role. How involved is the sibling? How aware is the sibling? I often will promote siblings to be actively involved, at least in the awareness of a child with a disability. They like to know what's going on with a child with autism, what they can do to be involved, and it helps them, see the child in a different light. It's, he invades my personal space not because he's a brat of a brother, but because he has a disability that he doesn't understand personal space. So sibling involvement is important too. Now, talking about medical conditions, prematurity is a big thing because, you can just understand, here's a little baby who's come out way before they were supposed to come out. And they're not really ready physically, developmentally. Now, this has become more common than we can imagine because advances in technology have increased the survival of what are called extremely low birth weight infants, less than 1,000 grams. And what this does is, with that increased survival comes the greater morbidity, greater risk of disability later in childhood. survival and morbidity are inversely proportional to the gestational age, which means that if they're born at 28-week gestation instead of the normal 40, they have a greater risk. But if they're born at 24 weeks, the risk is even higher. So there's this inverse curve on, greater the morbidity as lower is the gestational age. A lot of research shows that, even though the preterm infants are caught up, quote unquote, in some of the aspects of development, not all aspects are to be assumed to be caught up. They lag behind even later years. This is considered the longer range. Here's an example of what's called the mortality. We've gotten better and better, and right now, and this is a much older study in 2001, so we've even got better than this, is we are saving up to 50% of babies at 24 weeks gestation. I mean, that is a stunning thing. Babies who are born almost half the time before they were supposed to be born, we're saving almost 50% of them. But with that mortality improvement comes the disability, because as you can see here, disability rates climb. As there's a younger and younger in their gestational age, we are saving them, the greater and greater the disability. There's up to a 25 to 30% disability rate in what are called the extremely low birth weight infants. And the reason why prematurity causes risk for development is because it predisposes the infant to pathological events. So, for example, birth itself is a very traumatic event, especially natural birth coming straight through with the pressure and the movement. And you can imagine here's a very pliable, soft brain being subjected to these stressors. Also, normal intrauterine brain development, as we had talked about earlier, connections forming, growth, movement of the brain neurons. Well, instead of being exposed to that environment, boom, they're outside. So that has been interrupted. And so the combination of these things results in, severe exposure to both types of influence, the physical as well as the developmental interruption influence that can cause greater morbidity. Now, some of the studies have shown that the extremely low birth weight, or ELBW infants, less than 1,000 grams, when tested with neurocognitive tests, their disabilities included up to 9% of them have cognitive impairment, to 14% of them have cerebral palsy, up to 4% of them with hearing loss. But check this out. Only 26% of the total cohort were classified as quote-unquote normal outcome, which means 74% had something or the other wrong with them. 20% of them with major disabilities, 19% with minor disabilities. So, these low birth weight infants, these premature babies, are at high risk for having developmental poor outcomes. Cognition, what was found was that with every drop in birth weight, there was a greater and greater reduction in the IQ. And these IQ differences existed regardless of their home environment. So basically, we do know that the biology plays a very important role in these IQ lowering in these scores. Academics were also significantly affected because 50% of low birth weight, very low birth weight, that's less than 1,200 grams, and then 60 to 70% of extremely low birth weight, less than 1,000 grams, required some special ed services. And it shows that by middle school age, this shows the long-term effect of the premature outcomes, 3 to 5 times more likely to have a learning problem. And these learning problems generally, while they're not very different in the type of learning problem, they can have language-based learning disabilities and math learning disabilities, but the prevalence is increased fourfold. So it's not a unique type of learning problem, it's just a more prevalent form. Now, trauma is a very important factor that influences development because trauma is not just physical trauma. It's not just getting a scratch or breaking your arm. There's physical trauma, there's emotional trauma, and then there's trauma that we inflict as physicians through our procedures and medically necessary interventions. The physical trauma, there's accidental trauma. This is the commonest, where kid riding a bike falls off, hurts his leg, kid gets a scratch, etc. But there's also the more perturbing type, the non-accidental trauma, the child abuse, the shaken baby syndrome. We are not going to go into extensive detail about how child abuse and and physical injury that way affects children, because that's a whole talk in itself. But just as an example, a shaken baby it can cause devastating effects on development, because a child's brain is very flexible within the skull in terms of it's cushioned by fluid, and it moves a little bit. If a child is violently shaken, the brain basically bounces like a ping pong ball off the front and back of the skull, and that can cause direct trauma effects on the brain. But also, the other thing you have to understand, the blood vessels in the brain are very fragile and very thin, and they can be sheared and torn and cause bleeding. The bleeding in different areas can cause blindness, can cause cerebral palsy, can cause seizures, can cause the child not to be able to breathe. So these can again affect development. So that's an important factor. Emotional trauma, neglect, again, as we had seen earlier in some of those attachment studies that we had talked about, can significantly affect development, because the child does not get the nurturing, does not have opportunities to enhance their development. We also, as physicians, by doing surgery, we can cause the child to be taken away from their typical environments for some period of time. They can have minimal regression. It can limit their mobility. And we talked about some of those, just like chronic conditions, things that we do, the trauma that we inflict, even though we're doing it for a good cause, probably to save lives or to reduce disability, can cause effect on children's development. Medical neglect is one area. Again, this is an entire whole talk in itself, but it's interesting because we have to be a little culturally sensitive about this. Non-adherence, so medical neglect, is the act of not following medical advice. For example, you have a child in your office, has an ear infection, you prescribe an antibiotic, the mother refuses to give it to the child. This mainly can result from either one is most commonly a lack of understanding of what exactly you're doing, which means that we have to communicate better with families about our interventions. Why is it that I'm referring you for speech therapy for your child who doesn't speak? Another thing could be lack of resources, not being able to get places. We assume because we want a child to get something, they're going to get it. No, a family has to be able to go there, get it. Perhaps there's a copay, perhaps there's some effort involved, perhaps they're not motivated to get it for whatever reason. A good example is families who have a deaf child. There's a very strong deaf subculture where, they resist providing cochlear implants to their children because they believe that their child was meant to be deaf. They have managed to be successful being deaf. They can communicate with their child. They don't want their child's identity stripped from them. So lack of adherence, when it actually results in injury, it becomes medical neglect. So just because somebody doesn't give their child Tylenol when they have a headache does not mean you got to haul them away to court. However, if it can cause serious problems, a good example is if a child is in an accident and is bleeding profusely and you want to give a transfusion and the family refuses, well, that could be considered medical neglect, and you could say, I'm going to take your child away and transfuse. But the most important is to be aware of context. Cultural and religious situations sometimes take precedence, and good examples of this exist with Jehovah's Witnesses and certain sects of the Amish culture. You have to understand that for them it would be a major sin to receive blood in the Jehovah's Witness. So there have been courts upholding the rights of individuals because of their religious beliefs not to receive a transfusion or not to receive a transplant, even though they're aware of what the consequences are. And in these circumstances, it's almost always better to employ a team of people with ethicists and people who understand the community to talk about it, not just label people as medical neglect. But the reason I bring medical neglect up in the context of factors that affect development is that, things that families do intentionally or because they're unaware may also affect a child. A child who does not get speech therapy because a family believes that they're fine the way they are is affecting a child's development. And you have to take that into context. Always find out what is the family's awareness of what's going on, what is the family's concept of what's going on, and help to educate them and respect their wishes as long as you don't believe it's significantly disadvantaging the child. If it is, then you can pursue down a more aggressive course of having social services involved and an investigation into why this family is neglecting what you believe is in the best interests of the child. So, what I've tried to do here is try to to put into a tiny nutshell, a 2-hour nutshell, what would take a lifetime to understand. But it's to show you the varied and complex issues that are involved in child development. When you say factors, I have tried to encompass them, but they're too varied. Almost anything affects child development, and almost anything has a positive or a negative effect, not in isolation, in combination. So what I would encourage you to do is, when you look out there and you look at children and you think about what affects their development, quickly look around and try and put down on paper as an exercise what things you think right there in that room are probably impacting the child's development, and what you can do to sort of either enhance the factors that have a positive impact or reduce the factors that have a negative impact. And this would be wonderful to understand the bidirectional effects of factors, the interplay of environment and intrinsic, and the fact that we have control over some things, children and families have control over some things, society as a whole has control over some things, and fact that everyone has control over a few things and no control over many things. So, I would like for you all to read some of the references that we are going to put on the blackboard, and you can download or read online. There's also going to be a reference list that we're hoping to get to you on some of the key articles that I have referenced today, that you can go look up. Also, you can look up various resources that are out there. You can look at child development videos online, or you can get it from the Young Library. So there are several things that I wanted to close with. One is, child development is dynamic, it is exciting, it is influenced by things within and without that interplay with each other, and there is no more exciting field than trying to understand child development. And I want to thank IHDI for the opportunity to contribute to the graduate certificate class, and I will be more than glad to have you all contact me if you all have any questions. I will provide my email address if anyone is interested in communicating with me after this lecture. Thank you.